Welcome to Is It True? And hello again to my scientific co-host, Iva Milinkovic.
Hello again, Gerrit. What do we have today?
Well, in this fast-paced program, three leading experts in the world of implantology will challenge stereotypes and share their opinions on the questions everyone asks. Now, let's get this party started. Iva, what is the first question and who is the first expert introducing it?
So question 1. Is it true that guided or navigated implant surgery is more secure and predictable than the conventional brain-driven approach presented by Dr. Atiphan Pimkhaokham from Thailand?
Three major paradigm shifts of implant surgery has been noticed since its inception by Professor Brainmark. The first paradigm we call surgical-driven protocol. Implants were placed where the bone was. The second phase starts when the optimal position of the implant becomes important. Implant surgery then adopts a restorative-driven protocol. Recently, the advance of digital technology in dental field are transforming the way of implant surgery. Implant can be placed today minimal invasive with high precision by using digital diagnostic data such as cone beam CT, surface scan, combining with planning software, tracking system or surgical guide. All of this can describe as computer-assisted implant surgery or CAIS. As this is still an emerging technology, there is currently no clear classification of the CAIS. When we look at the literature, we can identify two common systems described often as static or dynamic CAIS. Static or guided surgery is a system utilizing fixed surgical guide which passively leads each implant drill into the bone precisely in the position where the implant has been virtually planned. On the other hand, the dynamic or navigated implant system allows for the freehand placement while offering real-time feedback to the surgeon about the exact position of the drill in relation to the planned implant position. This can happen because of tracking system that can follow the drill position in real time and relate it to the actual patient anatomy through the calibration process. From the review literature, there are limits of data which comparing the plan with the actual implant position when utilizing the CAIS technique, as opposed to the conventional placement in different situations such as single, multiple, or total edentulous patients. We report 5 RCT studies and we also investigate the outcome of the CAIS regarding several clinical outcomes, complications, patient report outcome in recent published clinical review. Regarding the accuracy of the implant position, both guide and navigated system demonstrate better accuracy when compared to the freehand technique significantly in all 3 clinical scenarios. CAIS was always significantly more accurate than freehand. However, when compared between the 2 CAIS systems, there was no significant difference. In conclusion, with a limit of data available, it's true that guide or navigated implant surgery is more secure and predictable than brain-driven approach.
Thank you, Atiphan Pimkhaokham, for telling us this is true. Now, Eva, Atiphan shows us so much evidence. I'm starting to wonder, why not use guidance in surgery?
Well, exactly. Dr. Atiphan has clearly demonstrated us that the use of guidance is associated with higher accuracy in implant positioning, and he has demonstrated scientific evidence for that too.
Exactly. Now, when I read the question carefully, what's new to me is the word secure and predictable. I'm aware what predictability means, but what is meant with secure in this context?
Secure, we want to stay in the safe zone related to anatomical structures and treatment planning. Predictable would be more in terms of where the desired implant will be placed. So if we plan the position, how predictably and accurately can we place an implant in this desired perfect position, let's say. So literature data has been dealing with this accuracy issue as well, and I think that recent meta-analysis and systematic reviews have demonstrated us that accuracy in computer-guided versus brain-guided implant placement has been much improved, and that this mistake or inaccuracy has been decreased.
I always thought it was called freehand, but I love this new term, brain-guided. I learned from the video from Atiphan that he is recommending, even in a single tooth, single implant situation, to use guidance. Do you agree with him?
If you want an implant in a perfect position, as we discussed earlier yesterday in Professor Herzl's video, you need the guidance. You cannot be that sure of yourselves that you're going to place implant perfectly in all 3 dimensions in the desired positions. So in that sense, what our narrator said makes sense, right?
Exactly, it makes total sense. So again, we've come to a new standards of best practice here at the EAO Congress. Thank you, Eva. Let's dig into our next question on Is It True?
Is it true that unhappy implant patients expected too much in the first place, or were they just insufficiently informed? Presented by Rino Burkhardt from Switzerland.
This is a truly difficult question, and I guess first we have to make clear that a patient who is unhappy with an implant restoration for whatever reason has to be diagnosed as orally diseased, because according to the actual definition of oral health, any condition or disorder that limit one's capacity in smiling and/or social well-being is associated with oral health. The main problem with surveys about patient happiness in clinical and medical research is based on the subjectivity of the various definitions of the term, respectively the subjectivity of the sensation of happiness. For that reason, researchers in the field of customer and patient happiness define happiness or satisfaction for the sake of simplicity as absence of dissatisfaction, which in turn is defined as non-fulfillment of the patient's expectations. At this point, it has to be mentioned, based on actual data, that implant installations associated with an aesthetic component lead to much higher risks of disappointed patients compared to implant restorations in the posterior area, which might be based on a communication problem between the doctor and the patient, which directs me to the second part of the title question and the relationship between the doctor and the patient. According to behavioral psychologists, one of the most complex interpersonal relationships that exists. There is no doubt that efficient healthcare required informed doctors and informed patients. In European countries, the media are an important source for patient information, but websites and magazines or brochures illustrated with decorative images focus more on the description of treatment and advantages than on risks of complications, and as such, they often create far too high expectations. That's why the communication between the doctor and the patient becomes so important. It belongs to the fundamental duties of the clinician to provide the patient with as much as possible unbiased information, without the omission of data that is needed for a democratically shared treatment decision. If there is a lack of transparency between patients and clinicians regarding communication before treatment, it might immediately result in a discrepancy between the patient's expectations and the clinical outcome after the implant treatment. Research data confirmed that patients' trust in doctors was associated with feeling extremely well informed, but which did not correlate with the objective knowledge scores. On the other hand, both doctors and patients are generally not able to accurately assess their level of knowledge and skill and may tend to be overly confident in their judgments, as described as well in the oral surgery literature. Besides the many described cognitive biases in medicine, The overconfidence error is one of the most predominant ones in the surgical field. To sum up, I would answer the title question with a distinct yes, with two critical remarks or comments. First, I say yes if we combine the two sentences in the title instead of an or with a because they were insufficiently informed. And secondly, I agree to the statement in the title, which is not the same as saying it's correct or false, because the latter would require a consensus in the research community. Now I'm curious to see what the implant community is voting, and I thank you for the invitation. Thank you.
Thank you, Rino Burkhardt. It is something to discuss, he says. Eva, what is your reaction to his video?
Professor Burkhardt has given a very broad and extensive explanation on the topic, and I completely agree with him that on converting this into a statement, a consensus is definitely required and needed. So an interesting point was that both patient and the doctor suffer from a cognitive bias called, I happen to know now, overconfidence error. So fundamental duty of the clinician is to provide patient as much as possible unbiased information about his or her treatment.
Yeah, so you say you agree and we should have consensus because the statement is twofold. It first says their expectations are too high and then they should have been better informed. That's a role for the professional in this case. He also mentions the media versus the professional, dentist or implantologist. Do you have any best practice advice?
Just to go one step back, like to make this into a statement and to prove this correlation, we need a consensus and we need a systematic review on this. But regarding media are now everywhere. You know, advertising has become much more accessible and much more affordable, and we are not talking only about TV, journals, commercials, we're also talking about social media. And there are certain, unfortunately, colleagues and clinics that advertise treatments and treatment plans and treatment options that could impact high and impossible patient expectations. So we really need to be careful about that. Never forget about basic principles, about what we learn as students, as postgraduate students, and throughout our career, because out of advertising, we cannot conclude, neither patients, but they unfortunately do, that one solution fits all and that one solution is going to be perfect for them.
Exactly. So if you take this into your own world, what do you do to manage expectations with patients?
I think we need really to stress this planning phase. Planning phase is not only done by dental team and by doctor, dental technician, so on. We need to do it together with the patient. As we mentioned yesterday, we have now these pre-visualizing techniques. We have X-rays, clinical photographs, advancements in that field that we can use to demonstrate our patient. But we also need to explain to her or him limitations and time needed for the desired or possible outcome as well.
Exactly. We are still in a medical profession and not in the profession of marketing, I hear you
Of
say.
course, and we need to stay there.
Exactly. Very clear. Thank you, Eva, for explaining and sharing this good advice. I think it's time for our third question of the night. What is the question and who is introducing it, Eva?
So, is it true that hard and soft tissue regeneration will become more patient-specific and hence more predictable with the aid of the technologies? Presented by Daniel Thoma from Switzerland.
Well, the question to some extent implies that we're currently treating patients according to a very standardized concept and apply the same technologies, the same treatment concept to every patient. This may not be true on the hard, but also on the soft tissue level. Well, currently, of course, we're using a lot of traditional techniques. We have several treatment options that at the end are tailored for every patient. I can well imagine that in the future, on the hard tissue level, we're using more patient-tailored treatment options. When we go to the soft tissue level, Also there, I can imagine that by applying newer technologies that we have patient-specific treatment. So I hope that in the future, of course, patients are treated not the same way, depending on the age group, maybe also the gender, but they get tailored and patient-based specific therapies.
Thank you, Daniel Thoma, for explaining why this is true. Now, Eva, regarding his opening remark, are we currently applying relatively standard protocols to our patients?
As the question said, do we need improvement? Well, actually, in terms of hard and soft tissue augmentation, we are currently performing relatively individualized protocols. We are all trained to provide treatments to our patients that are meeting patients' needs. So both in soft and hard tissue augmentation, we are going for treatment options that are individualized for each patient scenario. So therefore, I agree with Dani Thoma that we have already been providing that kind of patient-tailored treatment in terms of soft and hard tissue augmentation.
Exactly, but the statement is about it will become even more patient-specific in the future. What are aspects of the treatment or the protocol that will be mostly personalized and which are not at the moment?
In terms of hard tissue augmentations, the advancement in technology, mainly in diagnostical tools, but also in terms of soft tissue augmentations, could help us tailor more specifically towards each individual patient. Then we are definitely, as Dani said, aiming to provide individualized treatments for different patient groups. But where I also see the advancement potential place for the development in the future is, of course, the bioengineering. The use of tissue engineering, which requires, of course, we do have data and we do have studies both in terms of soft and hard tissue augmentations with the use of bioengineered structures. But cell biology, research and development, matrices, transmission signals, cell cultures, etc., is definitely here to stay and to develop more. And we, of course, need more long-term data on human model, which I'm sure that we will be discussing in a couple of years from now.
Exactly. And are you saying then when we specifically talk about soft tissue regeneration, we will not be harvesting again in the future?
I'm not here to say that. You know, being a periodontist, we are still aware of the fact that harvesting the autogenous graft is associated with the best results for now. But I can hope that bioengineering will be a friend in the future.
Exactly, something to talk about in some of the future EAO congresses. Perfect. With that, we come to the end of this session. We are wrapping up. We hope you learned a lot. Thanks to our experts and thanks to you, Eva, for all the additions.
My pleasure.
And we hope to see you back tomorrow for one more fast-paced Is It True session.